Hi, problem representation for this gentleman. I'm doing the infectious disease consult one. So I have a 78-year-old male skilled nursing facility resident who presented to the emergency department with complaints of shortness of breath and chest pain. Past medical includes MRSA, heart failure with reduced ejection fraction, 25%, coronary artery disease that's been stented, hypertension, and CKD with a 1.8 creatinine at baseline, and a 90 pack year smoking history. Denies current smoking, alcohol, or illicits. The initial workup in the emergency department revealed a white blood cell of 20, hemoglobin 7, platelet 165, sodium 130, potassium 3.3, chloride 95, BUN 34, creatinine 2.3, and a lactic acid of 4.5 EKG with sinus tach, and a troponin of 82. Right lower lobe infiltrates on chest x-ray and initial physical exam notable for confusion, bronchi to right middle lobe, cool extremities, and delayed cap refill. The patient decompensated in the emergency department, requiring rapid intubation due to acute respiratory distress. A CVC and A-line were placed, and he was admitted to the cardiac ICU due to NSTEMI and septic shock. Current vital signs in the ICU are 102.3 rectally, BP of 84/48, heart rate of 122, respiratory rate 16 to 98% on the vent. His weight's 142 kilogram. He's received a saline bolus, ceftriaxone, azithromycin, ASA, and a heparin infusion has been started. So acute sepsis with a heart rate of 122, a temp of 102.3, white blood cells of 20. Blood cultures are pending, and he's got an unspecified history of MRSA and a creatinine elevated to 2.3 from a 1.8. So I would go ahead and begin linazolid, 600 milligrams IV Q12 per wing et al. 2021. It's less nephrotoxic than Vanc, reaches higher levels of concentration in the lungs, and is effective against MRSA versa. And will also cover pneumonia, staph pneumoniae, Legionella, and other gram-negative or gram-positive infections. I also considered Dapto, but it doesn't have great representation in lung tissue, and ceftaroline, which isn't so great for bacteremia. So I would also continue the ceftriaxone 2 grams IV daily to capture Klebsiella and E. coli, but discontinue the azithromycin. And he'll have daily CBC and BMP. Those things pretty much address also the acute pneumonia that he's got with the nalazinid and the ceftriaxone. And of course, respiratory management in the ICU would be going on by the primary or pulmonology teams. So my two open-ended questions are, would you feel comfortable giving linazolid if the patient was taking an MAOI? Because there's newer evidence that it's safe and older evidence that it's not safe, and I'm not entirely sure where people fall on that. And then what do you think is the most likely infectious organism causing this presentation? Okay, thanks.